Hello and welcome. I am Dr. Jason Schmidt from the Vance Thompson Vision location in Sioux Falls, South Dakota, and Alexandria, Minnesota. And welcome to the Dry Eye Dialogue, your one-stop shop for all things dry eye related. I've got two of my esteemed colleagues here, Dr. Nick Risperud out of Fargo and Dr. Lorraine Zimprick out of our Sioux Falls office. So welcome, guys. And hopefully we have a fun hour or so talking about all things dry eye. Nick and Lorraine, anything to add before we get going here?
No, just happy to be here. Happy to talk dry eye with you.
Yep. Dry eye is can be tough to treat, so hopefully we'll make it an exciting little hour or so today talking about how we attack dry eye in each of our clinics.
Yeah, the goals today is to try to talk about some diagnostic tests that we use, new treatment options. Hopefully, we'll get into some good discussion, and then just ways to maybe implement a dry eye treatment practice into your offices there. So, before we get started, anything that you want? I usually like to start out with a fun fact that you could tell everybody. Like, Nick, I know you play a lot of golf. Lorraine, you're playing golf, but I've had a hole in one before. I don't know if you guys have had a hole in one, but that's my interesting fact about me. Nick, how about you?
No hole in ones.
No hole in ones?
No, interesting fact. I'll say I'll stick with the same I had. I had 23 cavities in my baby teeth growing up.
No hole in one for me. Um, I am not that good at golf. I'll be lucky if it goes in the direction of the hole. But fun fact is that I have shot a coyote with my bow.
That's awesome.
Yeah.
Was it running?
No, it wasn't running.
Was
It
it
was a
safe?
fairly easy target, but I don't hunt as much anymore, and I'd like to get back to it. So maybe it's somewhere in my future again. I don't think I'll ever have that opportunity again, but who knows?
Yeah. Well, this first section that we want to talk about, we're going to hopefully divide this into four groups today, but this first section is to talk about just a little bit of background of dry eye in general. Dry eye is not the most sexy thing in eye care, but it's real. It can be chronic for patients and, somewhat debilitating even, but a little bit of the background. So dry eye is a chronic, progressive, multifactorial disease. I say multifactorials, there's a lot of things that go into why people have dry eyes. Is it medications they're taking? Is it systemic conditions they have? Is it their environment that they're in? Are they contact lens wearers? And screens, we're on digital devices more than ever. You blink an average of 20 times a minute, but when you're on a screen, it goes down to like 2.5 times a minute. And so we're seeing this in a lot of younger kids now too, that they're just on more digital devices than ever before. But it's defined by increased osmolarity. So your tears get more concentrated. There's inflammation and there's neurosensory abnormalities. And I'll get to that a little bit later. 30 million people in the US are diagnosed with dry eye or have dry eye. 30 million have dry eye. Half get diagnosed. So only 15 million get diagnosed. So that's a big difference. And you think about that, 30 million people have dry eye in the US. If there's 300 million people, that's 10%. So if you're seeing 20 patients a day, two patients a day you should be diagnosing with dry eye disease. And it increases as we get older, about 2%. So a lot of number twos. So if you're remembering some things in this talk today, think of a lot of twos. 2% of your patients ages from about 18 to 20 or 18 to 35 have dry eyes, but it increases to over about 20% over the age of 75. And women are 2 times more prevalent to have dry eye than men. And about 28% of patients also have associated symptoms with allergies when they have dry eye disease. So a lot of things going on there. The tests to diagnose dry eyes have advanced a lot over the years. We still do some of these still. There's Schirmer tests that just measure the tear quality, tear volume, but they've advanced a lot to actually measure osmolarity and image glands, meibomian glands in the eye. So, Nick, what are your thoughts on these new advancements in diagnostic tests?
Yeah, Jason, I can say I'm really happy we have them because for me, dry eye, I think dry eye is tricky, and maybe I'm the only one, but it seems like my patients with the most clinical signs are not always complaining about their dry eyes. They're wanting LASIK surgery or refractive surgery, and they clinically have dry eye. I can see it, it's obvious, but the symptoms aren't there. Or some of my, patients with the most severe symptoms under the microscope, it's not that obvious. So signs and symptoms don't always correlate very well with dry eye, and that's where I think having these diagnostic tests to help us out um, really, help us nail the diagnosis. I think dry eye to me is kind of like keratoconus, where keratoconus prevalence now is increasing, and it's not that more people are being born with keratoconus today than they were 20 years ago. It's just that our diagnostics for diagnosing keratoconus have gotten better with corneal topography. I'd say same thing with dry eyes. People are not being born more now with dry eyes than before. It's just our diagnostics are allowing us to treat it, diagnose it, and treat it. And if, with increased, technologies to treat, we're more likely to, find it. It's not, it's not always easy to diagnose something when there's not many treatment options. Well, thankfully now with our diagnostic, with all the different treatment options that we have for dry eyes, we're diagnosing a lot more. So emergence of technologies like ocular surface imaging and tear film interferometry has greatly enhanced our ability to pinpoint the severity and type of dry eye. Utilizing a dry eye questionnaire, using sodium fluorescein to assess corneal staining and measuring homeostasis was found in one study to show 42% positive result in detecting dry eye disease. These tools provide a comprehensive view, aiding in accurate diagnosis and personalized treatment plans. There's two types of dry eye. One, aqueous deficient dry eye, found in about 15% of dry eye patients, and the big one is meibomian gland deficiency, responsible for about 85% of the dry eye out there, with approximately a third of patients having a mixed mechanism of dry eye, having some aqueous deficient dry eye and some meibomian gland deficiency dry eye. A lot of groups and societies created that have been, a lot of groups and societies have been created to target and treat dry eye. Most notorious, the Tear Film Ocular Surface Society, publishing our DEWS reports. They have recently developed a lifestyle report focusing on the U.S. economic impact of almost $4 billion lost due to dry eye, these patients having difficulty driving, reading, loss of work, pain, and irritation. They recommend switching to daily disposable contact lenses as opposed to our 2-week or monthly disposable contact lenses. Avoiding cosmetics with parabens, BAK, formaldehyde. BAK is interesting. I feel like since COVID, we are using like tons of hand sanitizers, or I use hand sanitizer more now than I did in the past. And a lot of the active ingredients on the hand sanitizers that we use, it's benzalkonium chloride or BAK. So the stuff that's killing the bacteria on our hands is often the preservative in some of these eye drops. So be on the lookout for these preservatives. Two more recommendations were keeping screen time to less than 2 hours a day, and then having environmental controls consistent with elevated humidity and stable temperatures in the house.
And I think that's right. I think with the hand sanitizers, people are getting them on their hands, and you don't realize how many times you touch your face or touch your eyes, and that stuff can get on your skin and it can irritate your skin and around your eyes too. But the part about the signs and the symptoms, that's totally right. And part of that is that there are 4 stages to dry eye. Stage 1, patients are asymptomatic. And so that's our job, is to kind of find those patients in stage 1 and to kind of identify that. Because if we don't, then they're going to progress and get worse. They're going to move into stage 2 and stage 3. And stage 4 is very debilitating. Hopefully you never see any of those, but it's the stage 1 patients. And that's the key, is to identify those. Just like when we go, to the dentist or go to get our annual physical, we may not have any symptoms of having 27 cavities in our baby teeth or whatever the case might be. But it's the dentist's job is to identify that you have a cavity and to do something about it, because if you don't, it's going to get worse. And when you go to get your annual physical, you may not have any symptoms of high blood pressure or high cholesterol or whatever it might be. But that's your doctor's job to identify that. And that's kind of what our job is, to identify those patients that are asymptomatic in stage 1, just so that they don't continue to progress and make it more difficult to manage down the road. The neurosensory abnormalities, I guess I wanted to go back to that a second. So it's a cycle. When your eyes are dry, you have inflammation in your tear glands, your lacrimal gland, your meibomian glands, whatever it might be. And then those glands can't produce tears very well. And so then your eye undergoes inflammation. And that inflammation then affects the sensory nerve back to your brain. So you don't get the feedback that your eyes are dry. So then you get less tear production, more inflammation, less feedback. And that's the key of breaking that cycle. And that's the difficult part, is 1, to identify it, but 2, to break that cycle and get the eye back to homeostasis, get the blink rate back to normal, get that lacrimal functional unit back to normal. So, well, as we dive into the next kind of section, there's a lot of treatments that are coming out or that we're using today. Lorraine, what are your thoughts on some of the modalities you found to be successful in your practice?
Yeah, great question. I just to like circle back, I said that to patients, what you said about like high blood pressure and things like that. I said that to patients so many times. And it's so true. It's like you go to, you go to your regular primary care doctor and they say, your blood pressure is high, or, you're overweight and you're borderline with diabetes or something. And one of the first things that they say prior to even like starting you on any medication is, there has to be some sort of like a lifestyle change, right? There has to be this is like the first form of treatment would be, you have to work out more, you have to eat healthy foods, and, care about what you're putting into your body and things like that. And so, it's like so similar with dry eye. It's, the patient that's borderline diabetes doesn't know that they're they would probably have no symptoms of that. The patient coming into our office for dry eye, coming into our office for who knows, whether it's like a LASIK, they want LASIK or a refractive consultation or cataract surgery, or glaucoma or whatever it may be, that we're getting these tests saying, hey, you've got dry eye. And there's things that you can change lifestyle wise. There's, drops or whatever medication there may be, but being aware of that's the same thing with dry eye, is that we're able to detect it almost before you're having any symptoms. And so how I kind of look at dry eye, or how I, in a sense, choose what tool in my toolbox I want to use, is kind of figuring out what is causing the dry eye. Someone mentioned before, or Nick mentioned before, like the types of dry eye, whether it's evaporative, if it's coming from our meibomian glands and those aren't working quite right, or aqueous, whether our lacrimal gland isn't producing what it needs to be doing, environmental, or whatever it may be. Understanding why the dry eye is there is going to be most helpful in determining what tool you use. And so, there's one of the first things that people use or reach for is artificial tears. And artificial tears are still a great treatment option. You can buy them over the counter, making sure that they're maybe a type of artificial tears that your doctor recommends. But there's types of artificial tears that can target the lipid layer or the aqueous layer or whatever it may be. So it can target, where the root of the problem. It can target the root of the problem. And so artificial tears are a great option. There's other drops or treatment modalities that we can use in our office, like plugs. Plugs are essentially plugging the drain. And so the tears that you create stay on your eye. And so that's really nice because it's your natural tears that stay on your eye. It's not an artificial tear. And so the more that we can keep natural tears on your eye, the better off that we are. Otherwise, going down, there's medication drops that you can use that treat, just like what Jason had mentioned, like this vigorous cycle that keeps going around. It's treating that inflammatory cycle. so that we can stop that pathway and get you feeling better. If it's a, meibomian gland dysfunction, there's in-office procedures such as intense pulse light or LipiFlow, modalities that in office we can kind of treat those glands and heat them up and pulse at them and increase that specific layer. The list goes on and on of things that we can do as far as in-office treatments. What do you guys reach for first? That's like kind of a fun question. I guess it really does depend on what type of dry eye they have. But let's just say you have a patient coming in and they're here for refractive consultation. They don't necessarily know that they have dry eye or care that they have dry eye, because we're the ones telling them, hey, we're starting to see the signs and stuff. Do you guys just go to artificial tears, or do you guys put them through a dry eye workup? Or what do you guys do?
I'll go first because Jason is probably going to sound really, really intelligent because this is, his area. And it's not necessarily mine, but I do like treating it. So I'm going to interrupt and go first. For dry, I mean, if patients complain about dry eye, first thing I look at is lids. I mean, the problem is statistically, the problem is likely with their eyelids. Okay. Either meibomian gland dysfunction or some blepharitis. Blepharitis is so common. And I mean, before we go to bed at night, we all brush our teeth, right? We wake up in the morning, we shower, brush our teeth, right? But we wash our hair every time we take a shower. I think, people do that. But how often do you wash your eyes? And it's like you're going to use soap and scrub your eyes. But we never would think we wash our hair. We brush our teeth, wash our eyes. We don't think of that. We should, because, looking at some eyelashes under the microscope can be pretty nasty. And so the purpose of our eyelashes are to keep stuff out of our eyes. So for people out there listening who maybe aren't optometrists or in the eye care field, the eyelashes pick up tons of stuff, and we got to get that stuff out. So I'm usually starting looking at the eyelids and then moving on from there. That's where I start. Jason, how about you?
Yeah, and if you're just listening and you're not actually watching this dialogue, Nick has amazing hair, and so he knows everything about
He
taking
knows
care.
all about washing hair.
He knows, he's got the routine down. So if you're not able to watch this,
He's got the flow.
you'll have to look that up later. I think you're right. These patients coming in for surgery. I'm hoping one that the referring doctor again is looking to diagnosis and start the patients ahead of time, so that when they come in, most of this is being managed. But sometimes patients are sent in on their own or come in on their own. And I think it's just getting back to the root cause. If I divide it in half, my aqueous deficient patients, I'm doing plugs and Restasis probably is my first step. If my meibomian gland dysfunction patients, I'm doing probably a heat treatment like LipiFlow or TearCare first, warming mask and fish oil. So that's kind of how I kind of break it down the middle. If it's more than that, instead of doing surgery, we'd probably take a time out, have them come back, repeat some things to make sure that we're getting them back on track and go from there. If it's just a strict dry eye patient coming in, again, it's kind of the same thing. It's just getting to the root cause. But yeah, I agree that, getting the eyelids real clean, blepharitis, there's actually so again, if you're not watching this, I don't even know if we're having this on video.
I don't know if people want to tune in to this,
well,
right?
These nasty lashes are what we see in the microscope. And so, all these little things on the lashes are actually in blown up mode, this giant bug that's in your eyelash, this mite. And so we want to get these things out of there because they get into the tear film, they irritate our eyes, and so you can't have those. So there's some really good drops out there that work on that. And, I've been amazed at how well they work. I don't know if you guys have used some of these things, but
I have.
In several weeks they're gone. And so it's good. Some of the serious patients, we make eye drops out of their blood. There's a way to make eye drops out of your blood. So we draw some blood, spin the red blood cells away, you get the clear plasma, we dilute that down, and that has the same biochemistry as your natural tear. So anything we can try to get something very close or similar to your natural tear, um, that's amazing. And so these drops have increased growth factors. There's platelet derived growth factors, and they're all compounded, and we just make them in the office, or we can send you to a place that can do that. But those things work really well. And then one more thing on just natural tears is there's a sensory nerve in your nose, and if we can stimulate that with a nasal spray, and maybe people have seen that around, but that works really well too. That you then stimulate your own natural tear production even more so.
One more thing I wanted to say is when you're first, addressing this patient with dry eye, what are you doing? Asking them what they're doing. Um, if they're using an artificial tear once or twice a day and they're doing well with that, that's actually me. So I wake up, I put an artificial tear in, preservative-free tear gets me going, and then I'll usually put one in before I go to bed. I don't consider myself to have chronic dry eyes. Um, I think artificial tears are really good at treating like situational dry eye. It tends to be cold in the Midwest, so you're driving, you got heat blasting in your face. And you get out of your car and your eyes are dry. Artificial tears work great there. I think if we expect, artificial tears to, treat chronic dry eye, or if a patient's using an artificial tear 6 or 7 times a day, there's something better that we can be doing, or there's something more that we can be prescribing for them. So artificial tears are awesome. We use them a bunch. They help really well with after surgeries. But when a patient starts using an artificial tear more than 3 or 4 times a day, we got to be doing more for our patients.
So I look at surgery, we need to get the tear film as pristine as possible before we do any eye surgery. And so diagnosing dry eye before surgery, I like to say that's the patient's problem. If we don't diagnose that before surgery and you start diagnosing it after surgery, well, now that becomes the doctor problem. And I think we just have to remember that we want to get good surgery outcomes. So we need to be better at diagnosing it before surgery so that we can get patients on a plan and they become part of that solution. Now, non-surgery, in eye practices and in optical practices that are doing glasses and contact lenses all the time. I mean, remakes happen, and you can have patients being frustrated that they're not seeing clearly, and those same rules apply to prescribing glasses and contacts too. So try to be more on top of diagnosing this stuff at the time of your prescribing glasses, and it may mean taking a time out as well, having them come back, make sure that the tear film looks better, and then prescribe glasses or contacts at a later date. So those are just kind of good rules of thumb.
Yeah, or like contact lens dropout. Patients are in our chair wanting LASIK, which we love that, and LASIK is always a great option. But one of the I always ask this question, okay, so you wear glasses and do you wear contacts? And they go, oh yeah, I wear contacts, but lately I've been wearing glasses because my contact lenses are bothering me. And they're just, by the middle of the day, I want them out. Well, I probably am going to want to work on dry eye treatment before LASIK, because number one reason of contact lens, discontinuing them is dry eye. And so assuming that my tests correlate with all of that, it would be my job to work on dry eye, maybe repeat scans, do whatever I need to do to make sure that they're prepped and ready for surgery.
It's a pretty good point. I was actually just writing up a case this morning of a gal that was referred to me last year for dry eye consult. She would wear her contacts like 14 hours a day. But it was so odd because she would say, my eyes feel better with my contacts in. And I wish I could take them out more, because I know I should, but when I take them out, my eyes hurt worse. And so for her, like, her eyes were so dry, her contacts were just acting like bandage contact lenses. Her contacts were acting like a Band-Aid. But that was the reason her eyes were so dry. So I started some therapy. I said, I'd really like you to, reduce your contact lens wear. I was supposed to see her back in a couple of weeks. I never saw her again until 6 months later. She showed up even worse. And we finally got her committed to the therapy. We did Sidra, we did plugs, we did Bruder mask, we did Avenova spray, short course of a load of prednisol steroid to get her going. And before she left, she said, can can I have LASIK? And I said, maybe someday, but like not right now. And 9 months actually from the first time I met her, we started therapy. She discontinued her contacts for 6 months. And then we just did LASIK like a couple months ago. So from the time I met her, 9 months later of therapy, she was able to have LASIK. But you've got to treat these beforehand because if you do LASIK on a dry eye, oh, you're asking for just, nightmare. It's
Well,
so tough.
outcomes are going to be
It is so tough.
unpredictable. The patient
Yeah.
experience is going to be
Mhm.
unpredictable, and so we just don't want any of that.
Mhm.
Yeah.
Um, Lorraine, you mentioned proper nutrition,
Mhm.
limiting, tobacco and alcohol in your diet. And, actually caffeine has actually been shown to be beneficial for dry eye patients. So that's good. But just sleeping better, having a good mental health state of mind and being, all those things are important.
Sleeping with a fan on. Um, when we go to sleep at night, just to add piggyback onto what you were just saying, we close our eyes at night and go to sleep, and sometimes their muscles are so relaxed they open just a tiny, tiny bit, and you have the circulation of the fan going on in the room, and that circulation can cause dry eye. So sometimes or worse, of course, in the morning, they wake up and they feel like they have to peel their eyelids open. Um, when we take a look at patients like that in the slit lamp, a lot of times all their dryness is on the inferior half. And then you start asking, okay, does their lid close all the way? Are you sleeping with a fan? Do you have a CPAP on? Some like environmental changes that they could make in their house or daily lives that would also treat this. Yeah.
I think that's a lot more common than we think. Patients get really surprised when I ask them if they sleep with a fan or sleep with a CPAP, and they're like,
Yeah.
"Holy, that's how'd you know?" And I can say, "Well, actually, I have that problem. I sleep. My left eye is always a little dry when I wake up in the morning because I sleep on my left side every night. Usually because my 3-year-old is next to me, putting her feet into my back, so I have to
Yeah.
roll away, and then my left eye is on my pillow, and my left eye doesn't completely shut." And so I have that problem. I know my patients also have that problem. But lifestyle changes with the sleep, that the fans are huge.
Yeah.
Yeah. A couple things too. I mean, you see a lot of, the gold standard that patients think is to use an eye drop called Visine, right? That helps to get the red out. If the eyes are dry, they're going to get inflamed and be red. And so this drop is really helping me because I'm getting the red out. And there's some other ones that are out there that have also helped to get the red out. But actually, these things over time can actually make your eyes more red and more irritated. So um, again, like Nick said, if you're using drops more than a few times a day and like every day, all the time, something else is going on. We got to get to the bottom of it. And Lorraine, I know you do a lot of glaucoma patients. I mean, even other drops that patients put in their eyes can have an effect
Oh,
on
yeah.
the ocular surface.
Yeah. I say like, don't get me started on patients with glaucoma drops. But it's starting to not be the first line of treatment for glaucoma. I would say the old standard of care was start treating patients by IOP or pressure lowering drops. And these pressure lowering drops, they serve a purpose, and the purpose of those drops is to lower the pressure and treat the glaucoma. The purpose is not to treat dry eye. And so, just like Nick stated before, these drops have preservatives in them that are toxic to the surface of the eye. And drops certainly have their part in glaucoma, but the better or the it's better for the patient if we can avoid drops. So if we can do a laser procedure or something else that we can make sure a patient is off drops, the better off their eyes are going to feel. And so, I see a lot of patients treat a lot of glaucoma, and a lot of them have red, irritated eyes, and sometimes that's the only option in some cases, but most of the time we're able to do a procedure or even get them on a preservative-free glaucoma drop is also very helpful, you know. But there's other diseases, not even just cataracts or cataracts and glaucoma, but there's certain things that can develop on patients' corneas or the surface of their eye from dry eye. Like we see a lot of what's EBMD, or epithelial basement membrane dystrophy, in patients. And that's just where the surface of your eye, the cornea, the epithelial cells are just kind of, it's like they're not quite as uniform as they should be. And they're kind of, mumbled and jumbled into an area, and that can cause blurred vision. And I always tell patients the reason why you have that is probably because of chronic dry eye. And so not only are we going to maybe do a procedure to fix those surface cells to be nice and smooth, but we're going to treat the underlying issue, which is dryness. So it might be plugs that we put in, or starting cyclosporine or something like that, to try to target the underlying issue so that doesn't come back even after our surgery. And all of these things, that I just mentioned, whether it's doing a procedure for the EBMD or the glaucoma or cataracts, I would say that surgery in general, to be free of glasses, is becoming very, very popular, right? Cataract surgery in a sense is a refractive surgery. And what that means is that more people are wanting to be free of glasses and free of reading glasses, or whatever it may be. They don't want to be in contacts. They don't want to be in reading glasses because of their lifestyle or whatever it may be. Just like the gentleman raising his hand. But when it becomes a refractive procedure, that's when dry eye and treating that and making sure that their eye is pristine and ready for surgery, that's when it becomes such a valuable part to that, is because people pay good money to be free of glasses and stuff, and we better have them prepped and ready so that they have a good outcome.
Your tear film interface is an important part of how you see. It has a refractive part of how you see. So if you don't have a good tear film, no matter what we do, the quality of vision isn't going to be there. So it's the tears, the cornea, the lens, the vitreous, the retina. Everything has to be taken into account when we figure out what's the best way we can get patients to see, whether it is glasses or contacts or surgery.
I think a lot of patients can get confused. Because I'll have somebody wanting LASIK, or having somebody wanting a multifocal lens for cataract surgery. And I've said before, I don't think you're ready for it yet. We need to treat this dry eye. And they say, I don't have dry eye. My eyes don't feel dry. And so I've started rewording I say, you're right. Your eyes don't look terribly dry. Your eyes may not feel dry, but this is a tear film instability issue. I can see your tears breaking up on the surface. Your tears are not stable. That is the first structure to refract light. So, dry eye patients might not grasp onto, because if they don't grasp onto the diagnosis and they don't believe you, they're not going to do the required treatment or do the recommended treatment. So even in the room, I've started saying, your tear film is unstable, and we need to treat that in order to get you ready for surgery. Because I've said dry eye before, and I actually get pushed back in the room because they're demanding that their eyes aren't dry. So switching the verbiage up and saying, like, tear film instability, we got to work on these glands on your eyelid first, getting you ready for the surgery to give us a better outcome, I found helpful, because patients won't abide to a therapy if they're not bought in, believing that it's going to be beneficial.
Yeah, I think that's an important point, Nick. I think, some of these point of service tests that we have, whether it's, checking osmolarity or inflammation, or if we're imaging the glands, or even a Schirmer's test, or the fact that we're using just stain on their cornea, just having a reason of how did we come up with that diagnosis, And like we said, stage 1 is asymptomatic. A lot of diseases are asymptomatic. Blood pressure is asymptomatic. Glaucoma is asymptomatic. 27 cavities is asymptomatic.
23.
7. Just add it. We're just going to keep adding to it.
Keep going up and up.
So I think that's important. Having that discussion with the patient, instead of having a discussion at the patient, getting the patient involved and having them understand what that's important. A couple things, there are some new products in the pipeline coming out. They kind of all do the same thing. They help decrease inflammation and increase tear production. RASP inhibitors, steroids that we put into the tear duct. There's topical minocycline ointment that helps improve inflammation. So there's some other things that we'll have in our toolbox to use as we go down the road. But so as we kind of go into the next segment, this is just kind of to further explore various aspects of dry eye disease, kind of like what we've been doing. But I don't know, Lorraine, do you have any burning questions you want to ask Nick that you haven't asked so far?
Take it easy on me.
Take it easy. I don't know. Um, how do you, so yeah, I mean, I don't do as many dry eye evals as Jason here. But what is your approach to patients? You know, you've maybe tried um a vast majority of things for patients and nothing seems to work, right? So, you know, the patient in the room, I have had it, but not as many. I don't see as many patients like this. But you know, you're rattling off, okay, we could try cyclosporine, and they say, nope, I've already tried it, that didn't work, and nope, I've done this, and that doesn't work. And so you've done a lot of things, and you've went down and maybe in office procedures or whatever it may be. But how do you approach these patients, you know, that are just very challenging?
Let me get
And
this
how do
straight.
you
Let me get this
get them in
straight.
a good
Yeah.
spot?
I said, take it easy on me. And then your question is,
This
how
actually
do
is
I
probably
handle
a
the
better
most
question for
difficult,
Jason.
driest patient? A good question.
Well, this is
I've done,
something though that like
no, it's tough.
I'm going to be learning from you guys. So,
I've done this once before. Yes, I'd say where it gets tough is like when the patient's been to multiple doctors. Well, and because they're frustrated. And so they have their primary optometrist. They've maybe been referred to a specialist, another, at my door. What have you tried? And I've got a list of stuff. And what are you doing now? Well, they're doing preservative-free tears, Restasis, cyclosporin. They have the heat mask. They're not doing it too much. They should do it more, but they forget. And you start adding these therapies or maybe taking some away, and you can really just get lost. What has the patient tried? What have they not tried? So I've done this before where I've said, you know what? Everything you have at home, stop. Stop doing everything. I've stopped every single treatment. Okay, you have a preservative-free tear at home, you can use that. But stop everything you're doing and come back in like 2 weeks. And then we just start adding things back on one by one. Um, a lot of patients come to our clinics. They're frustrated because they've been dealing with dry eye forever and they haven't gotten an answer. And, I'd say most of the time I'm throwing the kitchen sink at it. Like I'm, starting a low dose steroid, maybe doing some punctal plugs, and then treating the lids. And I'm doing a lot. But for like the most difficult of the complicated of dry eyes, where maybe I'm getting a lot more complaints than I'm seeing signs, and they tried most things, sometimes I'll just stop everything they're doing and then just add things back on one by one. So I know what's beneficial and I know what's not. Um, we've got some awesome therapies, awesome prescription drugs. No drug works for everyone. And the last thing you want is a patient on a drug that's adding no benefit. And so I've done that once or twice where I've literally just stopped everything and then added my therapies on slowly one by one.
you know, I have a very good approach to these patients. I say, you know, I have a partner here who is phenomenal in that area of expertise, and I'm going to send you over to his space. Jason, what do you do? Or how do you handle those patients when I send them over?
I try to get back to the root cause. Typically there's two things that are causing this. And I think with our diagnostic tests, I think we can figure out what the root cause is. And then I just have a strong belief that if I address the root cause, I'm going to get the patient in a good place. And so I think you just have to make sure you're addressing the right thing. Now, I'm checking cornea sensitivity a lot sooner than I've ever done before. So these kind of resistant ones, it's like, what is going on here? Why is this cornea still stained like it does? And I think that's a big thing that we probably have missed, or at least I've missed up until now, is I'm checking cornea sensitivity, and when I'm finding that hey, that cornea is not sensitive like it should be, I'm starting patients on oxyrvate a lot sooner, or I'm using amniotic membranes a lot sooner. And I think those two things are just super important things to like use in the clinic when you've got these cases that are just not making sense. So check cornea sensitivity sooner.
I would agree with that. I've used oxybate quite a bit up here in Fargo to treat, stage one neurotrophic. It does get tricky sometimes with insurance to get those medications approved. But if you fight hard enough, they usually listen. So keep fighting the good fight on those. But I agree with you, Jason. Use a cotton swab and just test the cornea sensitivity quick because you usually find something. You may be surprised.
And sometimes, there's obviously patients that are coming in that have dry symptoms, but their eyes are watery. That it's always the confusing. Well, how can my eyes be dry and they're watering all the time? Well, it's because the water gland is working. The meibomian, the oil glands aren't working. The oil is what coats your eye to keep the tears in your eye. And if you don't have the oil, your tears are evaporating faster than they should, and your eyes water. And so those patients are going to have more symptoms, like you said, in the car, heaters, fans, air conditioners running, outside, windy day, whatever the case might be. It could also be a surgical thing. And so that's another thing to keep in mind. Is their tear duct closed? Is their tear duct not in the right position? It's pointing outward. Are their lids loose? Are they on a CPAP machine? They've got floppy eyelid syndrome going on. It could be a surgical thing that needs to be addressed too. So you've got these cases that are real challenging, and you're like, I don't know what else to be doing. Well, maybe just kind of step back and think a little bit. Is the cornea working, or is this maybe a surgical case that I got to think about?
I agree, Jason. I think with watery eyes, physicians are pretty quick to diagnose just dry eye. Your eyes are dry, so they're watering. Um, yes, that does happen quite a bit, but I've sent a handful of patients to you guys over in Alexandria, Dr. Wristvet, because their lower eyelids are falling off their face. And it's, well, yeah, the tears aren't going to stay there. They're not going to stay on the surface because there's nothing there to hold them. So I feel like I've referred a handful of patients for a lateral tarsal strip just to tighten everything up. For these patients, I'll say, you can be driving a Porsche, but if the windshield's cracked, what good does it do? You can have a healthy eye, but if your cornea is dry and your lid, your wipers, aren't doing their job, nothing's going to help us. Drops aren't going to help. And, these lid LipiFlow and eye lock, they're not going to work because your eyelid is just sitting way down here.
That tension when they blink, that if the lid doesn't have any tautness when you're blinking, nothing's going to come out of that. We got to get some tautness back in. If that lid is super loose, it's just going to be like, a wet fish when you blink. So
yeah, and I have every once in a while I'll do a dilation irrigation, and I'm surprised every single time. It feels like where I'll try to shoot saline down the punctum, and I've emptied the whole thing, and I haven't passed any through to the throat. So I've also referred a handful of patients. Last time I did, a patient came back and said, "Thank you for listening. Thank you for doing something other than starting me on a new eye drop." Because after my DCR surgery in town here, it's the first time in 3 years my eyes have stopped watering. So I would say, yeah, watery eyes, epiphoria, probably dry eye a lot of the time. Not always.
not always.
Jason,
Well,
one quick question.
yeah.
One quick question on that. When you, or either of you, I guess, when you do Jones testing and you find that it is stenosed, do you guys start them on any treatment initially, or do you just send them right away to ear, nose, and throat?
So I kind of base that on how long it's been happening,
Sure.
and it's like both sides, because that's weird that it would be both sides, right?
Yeah.
So maybe it's like just some recent onset inflammation. So I try to start patients on a nasal steroid spray first, um,
Yeah.
just because there's something blocking down in there, and a drop can't maybe get to where I need to go. So I start them on a nasal spray, a steroid nasal spray like Nasacort or Nasonex or
Yeah.
something like that, twice a day for like 3 weeks and reassess. And I bet probably a third of those open up. But when you hear from the history that this is more long term, this has been going on for
Yeah.
several years, you also ask if they had any prior like nasal surgeries or sinus surgeries and things like that. Because if they have, then they probably need a DCR.
Yeah. Very good.
Well, I think we've got maybe another 10 or 15 minutes to go here. Um, in the final part, I just kind of want to talk about implementing strategies into a practice. So we talked about all the diagnostic tests and ways to assess this and new treatment modalities, but where do you start? It seems like a lot for people to like, I don't know where to start. So Nick, do you have a suggestion on how do you start bringing some of this to reality?
Hmm. I think first, I wasn't always passionate about dry eye, to be honest with you guys. I found it frustrating to treat in school. And you got out in the real world, and I realized like how many patients are actually struggling with this. So I'm trying to, because bottom line, you won't be good at treating something if you don't enjoy treating it. Um, so, committing to it, committing to, maybe acquiring another piece of technology or another diagnostic to help you. Um, just creating like a streamlined approach to customized treatments, for each patient. Um, Unfortunately, insurance, comes into play sometimes of what you can, bill for, what you can collect, whether insurance will cover a diagnostic test or not. But I rely on a lot of diagnostics to help me make the diagnosis instead of just what my eyes see in the slit lamp. Um, for us, we're usually hammering it hard before our surgeries. So for me, I'd love for these patients to, get here already treated, already on a treatment plan. Um, but if I'm going to start implementing, dry into my private practice or, you know, start with the basics, I don't always stain patients with sodium fluorescein. If I'm going to do more, I'd start staining everybody and just getting better at finding these things. And I think, uh, measuring osmolarity is really simple and fast. And then, something to image the lids and help us out. Because those aren't always, that's not always easy to catch. So I'd start, measuring osmolarities, checking for inflammation, and imaging the lids can just be really helpful.
Yeah, I would I think that's great. Like the latter, I liked all of what you said. I would say if I was going to implement dry eye into my practice, it's it can be very like you can do it cheap, right? All you really need is sodium fluorescein and your fingers, because you can put sodium fluorescein in the eye and you can tell if there's any inflammation, any SPK. You can test tear breakup time, and you can also pull the lid down and express the glands. And between those three things, you're almost going to be able to determine what the root cause of the dry eye is. Of course, all the other diagnostic tests that we have are able to like quantify things and give us certain values and give us these values that if we do, LipiFlow or tear care, or whatever we may do, if we do an in-house modality, 3 months later we can repeat the test and see that the quantity of that grew. And so it's nice to have those tests, but implementing dry eye into your practice doesn't have to be that expensive. And one thing that I think is implementing this is to know that it does take some educating on your regular, well, if you're in a primary care practice, your regular patients, explaining to them, hey, if your eyes are, it's just a simple question, or a speed questionnaire, something that we can say, hey, I saw you filled the sheet out and it looks like you have burning eyes, 3 days a week. Then this exam could transition to a medical exam, right? That can transition to a medical exam, or you can finish the vision exam and say, hey, come back and I'm going to put you through a dry eye eval and, figure out what the cause of this is. And that can go to your medical insurance. And so I think it can be very easy to implement dry eye, but it also, you can get lost in the weeds on what equipment to buy, when you're wanting to do that, but you don't necessarily need it.
Yeah, I agree. I think there's a study that I remember now that I think it was Cooper Vision did years ago, that an average patient in a private optometry office generates $30,000 over a lifetime. And that's by keeping them happy and seeing well and whatnot. And you don't want to lose those patients because they're struggling with not being able to see, their contact lenses aren't working, and those patients then jump and come into our office and want to have surgery. So keeping them in your office is important. So financially, that's a reason to try to, what can I do better to manage these patients? Second is, implementing dry eye can be financially lucrative as part of your practice. You can turn your vision insurance exam, like you said, maybe into a medical exam, and then having them come back again for a repeat visit for that. And if you're saving on remakes and contact lens chair time and those kind of things, that can also help improve the bottom line in your practice. So you don't need to have all these things, but the AOA recommends two things: do an objective test and do a subjective test. So the objective test is the questionnaire, and the subjective test is stain in your finger, push on their glands. And if you want to invest in measuring osmolarity and inflammation, those tests reimburse as well. And so you can do that. Some of these bigger in-house treatments are not covered by insurance, and that's a good thing. And we charge patients over $1,000 for some of these things, and they need it, and it works. And so those are things that you can kind of build up to if you want to, but it can really end up helping the bottom line of your practice to grow. So, kind of to wrap it up, I thank you both for joining today. There's a lot of valuable insights here. This was a wrap up of today's dry eye dialogue. I'd like to have our listeners tune in to understanding the nuances of dry eyes more by attending some of these lectures that were coming up. We've got 2 new lectures coming up here in the next, one in Sioux Falls, February 24th. We're having a big symposium in Sioux Falls to learn more about all things eye, and one in Alexandria on April 18th to learn about additional things related to the eye. And patients or doctors can come into our offices anytime they want and spend half a day or a day with us and go over like a little mini fellowship where we can learn even more about dry eye disease and hands-on learning. So, until next time, I guess, stay curious and keep learning. The world of eye care is ever changing, and so are we. I want to thank Lorraine and Nick for engaging with us today. Make sure you visit our website and follow us on social media for additional resources and updates. Tune in next time for an awesome discussion on the Sharp Science Sessions, all things LASIK. Well, I'm your host, Jason. Take care and good night.
Thanks, Jason.